What's new in clinical trials? My name is Kevin Mackey, and I'm at Indiana University in the Department of Applied Health Science in the School of Public Health in Bloomington, Indiana, and also with the Midwest Biomedical Research Organization in Illinois. And these are my disclosures. Recent clinical trials have investigated both sides of the Apo-B coin. And when I say both sides, what I mean is one side being triglyceride-rich lipoproteins, and we've had a lot of activity there with Icosapent ethyl, omega-3 carboxylic acids, an antisense oligonucleotide against ApoC3, and Pemafibrate, a PPAR-alpha modulator. On the LDL side, the cholesterol-rich lipoprotein side, we have recent approval of Bempedoic acid. We have a new PCSK9 inhibitor therapy that has been in development and has applied to the FDA for approval. And then we have Evinacumab, which is a monoclonal antibody against ANGPTL3. So I'm going to briefly discuss clinical trial results relevant to all of those therapies. So in 2018, early in the year, there was a lot of controversy about the role of omega-3 fatty acids and their potential for use in reducing cardiovascular event risk. There had been a very high-profile meta-analysis done by Ong and colleagues in which they concluded that there was no benefit of low-dosage omega-3 fatty acids. Nearly all of the studies in the meta-analysis had used a low dosage. And having said that, there were 4 ongoing trials that had the potential to, really tip the scale to one side or the other in favor of benefit or no benefit. And those trials were Ascend, Vital, Reduce It, and Strength. And so later on, once the results from Ascend and Vital were available, there was a meta-analysis done by Joanne Manson and her colleagues at Harvard, and they updated the prior meta-analysis, and the results showed that for low-dosage omega-3 therapies, when I say low dosage, I mean less than 2 grams per day of long-chain omega-3 polyunsaturated fatty acids, there were modest but statistically significant reductions in myocardial infarction, coronary heart disease death, total coronary heart disease, and CVD death. However, for the low dosage studies, there was no evidence of benefit for stroke. And so the updated meta-analysis substantially increased the number of participants from about 77,000 up to nearly 120,000. And so again, the results were consistent with a modest but statistically significant benefit for cardiac outcomes, but not for stroke. And then, of course, the results from the Reduce It trial were released at the end of 2018, and that is a higher dosage EPA therapy, Icosapent ethyl, and for the primary outcome variable, there was a 25% reduction in major adverse cardiovascular events. And then when the Reduce It trial was added to the meta-analysis I just mentioned, the results were further strengthened in favor of benefits for myocardial infarction, total CHD, and CVD death. And while there was a 28% reduction in stroke incidence in Reduce It, that wasn't enough to offset the lack of benefit in the other studies. So the only study for which we have strong evidence of a stroke benefit is Reduce It with Icosapent ethyl, and the low dosage omega-3 trials have not provided evidence of benefit for stroke. Now, what I call the tallest of the low-dose studies, the low-dose studies with the highest dosage provided was JELIS. And this was a study done in Japan. It was a combination of primary and secondary prevention patients. And overall, the results showed a 19% reduction in the primary outcome variable, which was major adverse coronary events. And the investigators did a post hoc analysis where they treated the data as if it were from an observational study. So they pooled the groups together, they divided them into segments based on plasma EPA level, and they found that those with a higher plasma EPA level, at least 150 micrograms per ml, showed the greatest evidence of lower cardiovascular event risk, specifically major coronary event risk. And so this suggested that plasma EPA level may be an important determinant of the benefit of therapy in that trial. And so I'm sure you've all seen the slide from the REDUCE-IT trial showing the effect of Icosapent ethyl on various biomarkers of cardiovascular risk. There was a reduction of about 20% in triglycerides. There were also significant reductions in non-HDL cholesterol, LDL cholesterol, HDL cholesterol, Apo-B, hsCRP, and there was an increase in EPA from a baseline of about 26 micrograms per ml to a one-year value of about 144 micrograms per ml, which is similar to the value that was achieved in the JELIS trial, even though the dosage was lower in the JELIS trial of EPA. There's more fish consumption in Japan, and so the two studies were roughly similar with regard to the EPA level achieved. And there was a post hoc analysis completed for REDUCE-IT that evaluated the relationship between plasma EPA level and the degree of reduction in major adverse cardiovascular events. And so what they did is they, one by one, adjusted for differences between the treatment arms with regard to biomarkers. So when they adjusted for triglycerides, which were different between the treatment arms, it had very little effect on the estimate of the benefit. And so if a biomarker is mediating the benefit, so if the reduction in triglycerides was mediating the benefit, you would expect that if you adjusted statistically for the difference between the groups in that biomarker, it would narrow the effect of the treatment. And so in this case, it barely budged the effect of the treatment from 0.75 to 0.77. And that was true for all of the other biomarkers except EPA level. When there was an adjustment for the difference between the groups in EPA level, you saw the treatment effect disappear. And that is consistent with the hypothesis that elevation in plasma EPA was mediating the benefit through mechanisms that at this stage are not fully understood. Now, they further looked at the dose-response relationship, and what you see is that the higher the plasma EPA level went, the greater the benefit, and that was true for multiple variables. I've shown a subset of the variables here: the primary endpoint, key secondary endpoint, cardiovascular death, and total mortality. And what you see, especially for the primary endpoint, is a relatively linear reduction in risk as plasma EPA level goes up to at least 200 micrograms per ml, after which the relationship flattens out some. And so, again, this is consistent with the hypothesis that a high enough level of plasma EPA is needed to observe a benefit with EPA therapy. Now, another study had results that were just presented recently at the ESC meeting, and then there was a paper that was simultaneously published in European Heart Journal, and that was the EVAPORATE trial that looked at the effect of Icosapent ethyl on progression of coronary atherosclerosis using CT angiography. And this trial enrolled patients with elevated triglycerides and having at least one coronary artery that showed narrowing on CT angiography, and all of the subjects were taking a statin with or without Ezetimibe. And they were randomly assigned. It was 80 subjects who were randomly assigned to Icosapent ethyl 4 grams per day or placebo, and then followed for an 18-month period with follow-up CT angiography to evaluate the degree of progression of coronary plaques. And the primary outcome variable was low attenuation plaque, and you see that on the far left. In the Icosapent ethyl group, there was a 17% reduction, and then there was a large increase in the placebo group of 109%. And although this has created some controversy because the increase was so large in the placebo group, I think there are a couple of things to consider. One is that only about 5% of the plaque at baseline was low attenuation plaque. And so there may be an element of the small denominator effect here. When you have a small denominator, a relatively modest change can produce a large percentage change. And then in addition to that, the investigators report that the degree of progression was very similar to that in the placebo group from another study that they undertook, the Garlic-5 trial. And so, that was a very statistically significant result. And then for all of the other CT angiography variables, fibrofatty plaque, fibrous plaque calcification, non-calcified plaque, and total plaque burden, there were either near significant or significant differences favoring Icosapent ethyl. For calcification, the adjusted p-value was just over 0.05. All of the other p-values were less than 0.01. And so this is suggestive that the benefits observed in the REDUCE-IT trial and the JELIS trial may have been at least partly attributable to slowing and even reversal of the atherosclerotic process. Now, I was feeling really good about the effects of omega-3 fatty acids after results from trials like REDUCE-IT and VITAL, which was a very large primary prevention study that showed a benefit for coronary heart disease, but not for stroke, as has been the case with low-dosage omega-3 trials. And so I was really expecting that the STRENGTH trial would also show a benefit. This was a study of 4 grams per day of omega-3 carboxylic acids, that's EPA and DHA. And it was a very large study, about 13,000 subjects, all of whom had triglycerides at least 180 milligrams per deciliter to 499 milligrams per deciliter and below average levels of HDL cholesterol. And unfortunately, the study was stopped in January 2020 after an interim analysis, basically for futility. And so we don't really know the details at this point. We should hear some details at the American Heart Association meeting in November. So I won't speculate too much as to the reasons that the trial did not show a benefit. This was a study that was about half primary prevention, half secondary prevention. And given the large sample size and the groups under study, I was very optimistic that this would show a benefit, but that was not the case. So that is a bit confusing at this point, and we eagerly await more results at the American Heart Association. So there are some open questions with regard to omega-3 fatty acids for ASCVD risk reduction. Right now, the best evidence we have is for high dosage EPA therapy. And one important question is what would be the contributions of the various mechanisms for the observed benefit? So there are effects of EPA on inflammation, oxidation, platelet activity, lipoprotein lipids, fibrosis, atherosclerosis, and arrhythmia. And at this point, we don't have clear evidence to indicate the relative contributions of all of these potentially favorable effects of therapy. Another question is whether benefits are limited to patients with elevated triglycerides. In both JELIS and VITAL, these were samples that were not selected for elevated triglycerides. And so that would suggest that elevated triglycerides may not be a prerequisite to seeing benefit from therapy, although we need randomized controlled trials to demonstrate that. And another question is how close we are to the point where it might make sense to target either a plasma or other biomarker level of EPA or omega-3 fatty acids. So we need trials to evaluate the hypothesis that we should be treating plasma levels or biomarker levels of omega-3 status as a risk factor, just as we would for LDL cholesterol or blood pressure and so forth. So more trials needed before we can advocate such an approach, but it certainly seems plausible. Now, again, continuing to focus on the triglyceride-rich lipoprotein side of the coin, prominent is an ongoing trial with Pemafibrate, which is a PPAR-alpha modulator. It's about 10,000 participants in 24 countries, all men and women with type 2 diabetes, elevated triglycerides, low HDL cholesterol, all taking statin therapy, about 1/3 primary prevention, 2/3 secondary prevention. And the primary endpoint is MACE plus, which is major adverse cardiovascular events of MI, stroke, and then unstable angina requiring unplanned revascularization. And so Pemafibrate, like other fibrates, lowers triglycerides, it lowers ApoC3 levels, it tends to increase HDL cholesterol, and in patients with more moderate elevations in triglycerides, it tends to lower LDL cholesterol, but in patients with more severe hypertriglyceridemia, like other fibrates, may somewhat raise LDL cholesterol. Another agent that is in development is an antisense oligonucleotide with GalNAc technology, which inhibits ApoC3 protein synthesis. And so this is an agent that is sort of a second generation. Volanesorsen was an agent that had some issues associated with it and did not receive approval from the FDA for treatment of familial chylomicronemia syndrome. But this is a new generation of that type of therapy that requires a much lower dosage because the GalNAc technology allows a much lower dose to be administered with targeted delivery to the liver. And there was recently a presentation of phase 2 results that looked at 115 men and women with cardiovascular disease and elevated triglycerides who were receiving standard of care preventive therapy. And the primary outcome for that study was triglyceride reduction. And there were 4 groups in addition to placebo, a group that received 10 milligrams every 4 weeks, and that group showed a 23% reduction in triglycerides. There was a group that received 15 milligrams every 2 weeks, and that group showed a 56% reduction in triglycerides. Then a group with 10 milligrams every week, 60% triglyceride reduction, and another group with 50 milligrams every 4 weeks. That group also had a 60% reduction in triglycerides. You can also see that there was a progressive increase in the percentage of patients that achieved a triglyceride level of less than 150 milligrams per deciliter, ranging from 14% with 10 milligrams every 4 weeks up to 91% with 50 milligrams every 4 weeks. So this looks very promising for both triglyceride lowering and for producing other favorable effects on the lipid profile. So as you would expect, ApoC3 was significantly reduced, VLDL cholesterol reduced, non-HDL cholesterol reduced in 3 out of the 4 groups. LDL cholesterol was not increased. Apo-B was reduced in 2 out of the 4 groups, statistically significantly. And then all of the groups showed significant increases in HDL cholesterol and ApoA1. Now I'll turn my attention to the LDL side of the Apo-B coin, and there's a new agent, a new arrow in the lipidologist's quiver for managing LDL cholesterol, and that's bempedoic acid. It's a small molecule ATP citrate lyase inhibitor. And both of the forms, it's been approved as a standalone agent and then also as an agent that's co-delivered with Ezetimibe. Both are indicated as adjunct to diet and maximally tolerated statin therapy for treating adults with heterozygous FH or established ASCVD who need additional LDL cholesterol lowering. There is an ongoing cardiovascular outcomes trial, but the results from that are not yet available, so we don't know yet what the evidence is going to be for cardiovascular event risk reduction. And the phase 3 program had multiple studies, all of which had clear in the title. So there was clear harmony, wisdom, serenity, tranquility, and then, as I mentioned, the ongoing clear outcomes trial. And the results from these trials have been very consistent, roughly a 15 to 20% reduction in LDL cholesterol. And in addition to reductions in LDL cholesterol, there are reductions in non-HDL cholesterol, triglycerides, Apo-B, and hsCRP. Again, very consistent results. And the effects appear to be roughly additive to those of ezetimibe. So when patients are evaluated on ezetimibe, bempedoic acid, or the combination of the two, the combination produces roughly an additive effect with regard to reductions in LDL cholesterol, as well as reductions in non-HDL cholesterol and Apo-B. Another drug that's been in development and has submitted to the FDA for approval that is expected potentially very soon is Inclisiran, which is a synthetic small interfering RNA drug that inhibits translation of PCSK9. And it's administered as a subcutaneous injection with an initial dose, then another dose at 3 months, and then dosing at 6-month intervals thereafter. And as I said, a new drug application has been submitted to the FDA with a proposed indication for secondary prevention patients in patients with ASCVD and for heterozygous FH. Now, looking at the effects, the Orion program had a number of trials that have been evaluating the effects on the lipid profile. The results, again, have been very consistent with 50-ish% reductions in LDL cholesterol. Here are results for Orion 9 and Orion 10. And then in Orion 11, you see, again, relative to placebo, very close to a 50% reduction in LDL cholesterol. And on this slide, I also show the results for PCSK9. As you would expect, PCSK9 levels are substantially reduced and generally have been reduced in the neighborhood of 60 to 80% relative to placebo. And so this drug is exciting in the sense that we know that there are adherence problems and persistence problems with lipid therapies, even those that are very effective and well tolerated. And so this offers the potential to give a patient an injection that lowers their LDL cholesterol level for a period of 6 months, which may be very helpful with regard to ensuring adherence to the therapy, because you only need to have an injection once every 6 months after that initial period. Evinacumab is another agent. It's an ANGPTL3 monoclonal antibody. So it's a monoclonal antibody that inhibits ANGPTL3. And ANGPTL3 is known to inhibit lipoprotein lipase and endothelial lipase, and also influence assembly of VLDL particles in the liver. Loss of function variants for ANGPTL3 have been associated with hypolipidemia and protection against ASCVD. So Evinacumab lowers both LDL cholesterol and triglycerides, and it's been studied in homozygous FH, and the FDA has accepted an application for priority review as a treatment for homozygous FH, and a decision regarding approval is expected early next year. This figure just illustrates that you have hepatic secretion of VLDL. ANGPTL3 influences lipoprotein lipase and endothelial lipase. And so if you have higher levels of ANGPTL3 or higher activity of ANGPTL3, that's going to slow down clearance of triglycerides and clearance of VLDL remnants. And so if you inhibit ANGPTL3 with a monoclonal antibody, you'll reduce the number of VLDL particles being secreted. You'll also increase the rate of clearance by taking the brake off of lipoprotein lipase and endothelial lipase. And in addition to that, you accelerate LDL receptor independent uptake by the liver and other tissues of VLDL remnant particles. And so the net result is a reduction in both VLDL particles and triglyceride levels and of LDL concentration. And because you get an acceleration of non-LDL receptor mediated uptake of particles, that can be very beneficial potentially in patients with homozygous FH. And so these results are shown here for the ELIPSE trial. You have a 47% reduction from baseline in LDL cholesterol compared to about a 2% increase with placebo. And then you see similar reductions of 40+% in Apo-B, non-HDL cholesterol, and total cholesterol relative to very little change in the placebo group. So in summary, new data suggests that benefits observed in the REDUCE-IT trial with Icosapent ethyl may not have resulted primarily from triglyceride lowering. Pemafibrate is under study in a cardiovascular outcomes trial, prominent in subjects with type 2 diabetes plus elevated triglycerides. And with Pemafibrate, you see reductions in triglycerides in the neighborhood of 50%. An ApoC3 antisense oligonucleotide drug with GalNAc technology is under study that lowers ApoC3 levels and lowers triglycerides substantially, and that looks very promising. Bempedoic acid has recently been approved by the FDA and lowers LDL cholesterol by 15 to 20% with effects that are additive to those of both statin therapy and to Ezetimibe. Inclisiran, a small interfering RNA drug against PCSK9, is under FDA review with administration every 6 months, producing a 40 to 50% reduction in LDL cholesterol. And Evinacumab, an ANGPTL3 inhibitor, is under FDA review as a treatment for homozygous FH, reducing LDL and non-HDL cholesterol by 40 to 50%. So the lipidology field is expanding rapidly in terms of the tools that are available to clinicians, and so it's a very exciting time to be in the field.